Clinical correlation. You have a 20-year-old male presenting to the team physician unconscious for 5 minutes after missing the pole vault pit and landing with the occipital region of his head hitting the asphalt. After assessing his airway, breathing, circulation, and finding them intact, the patient's level of consciousness was evaluated. The patient's eyes, initially closed, were opened when the sound of his name was spoken. And when asked where he was, the patient responded, "My shoes to change." The patient moved all of his fingers and toes when he was prompted. What is this patient's score on the Glasgow Coma Scale? So what is the Glasgow Coma Scale? It's a neurological scale which aims to give a reliable and objective way of recording the conscious state of a person for the initial as well as the continuing assessment. A patient is assessed against the criteria of this scale and results in what is given as the Glasgow Coma Scale, or GCS. It basically quantifies this level of consciousness. It can help determine whether there is more acute brain damage or less acute, less damaging brain damage. It assesses the initial level of the consciousness and then can be used throughout the patient assessment to determine any changes in this consciousness. It helps to guide our treatment and predict an outcome, whether it's better or worse. The scale consists of 3 individual tests that add up to a total score. The tests go over eye, verbal, and motor responses. The 3 values are then determined separately, and then they are summed together. The lowest possible score is a 3. It's a deep coma or even death. A rock would have a GCS of a 3. A dead person for 6 weeks would have a GCS of 3. A person that is in a deep coma but still alive would have a GCS of 3. The highest a person can be is 15. That is fully awake. That is you and I currently. Stimulation can be either verbal or nonverbal. It could be their name spoken loudly. It could be a pinch. It could be a yelling of, "Hey, are you okay?" It could be a poke. It could be a movement or a shake. Some sort of stimulation. And then we look at the 3 categories. Whether their eye opens, they have some sort of verbal response, moan, groan, their name, their history of what's going on, or inappropriate words. And then we check their motor response. Can they follow commands? Do they move? Do they pull away? Do they push you away? Or do they posture? The Glasgow Coma Scale is best written out such as this. The best eye response with a 1 through 4 category. Best verbal response 1 through 5. And best motor response 1 through 6. 6 plus 4 is 10, plus the 5 would be 15. So the best you can get is 15. The worst you can have, or the lowest you can have, is a 3. It can actually be worse not having that 3, and I will explain that later. But this is your GCS scale for the adult. As stated before, eye has 4 different grades. 1 being the most severe, which is no eye opening. 2, eye opens in response to pain. You pinch the nail bed on a patient, or you give them a sternal rub and their eyes open. If you call their name and their eyes open, this is eye opening to speech, which is a level 3. This is not to be confused with people who may be sleeping, such as patients of that sort will have a 4, not a 3. Once you get their attention, they are more alert and looking around. They're considered a 4 because they open their eyes spontaneously. You guys have already seen this scale. It is very similar to AVPU. Either they're not going to have eye opening or they're unresponsive. They open their eyes to pain or painful response. They open their eyes to verbal or verbal response, or they are alert and they open their eyes spontaneously. So if you have already memorized your AVPU scale, you have already memorized 1/3 of your GCS. Verbal response. There is 5 grades, starting with the most severe. 1 is no verbal response, nothing, no sound whatsoever. 2 is incomprehensible sounds. That's going to be moaning, no words, just moaning and groaning, mumbling. 3 is going to be inappropriate words. They're actually formed words, but they don't make any sentence. They don't make conversational exchange. You can say, "Hey, ma'am, can you hear me?" And all you get in response is cheese. Cheese. It's not appropriate. It's a word, yes, but it is not an appropriate word for what is happening at that time. 4 is they're confused. You say, "Hey, ma'am, how are you doing? What's going on?" And she says, I don't know. Who are you? Where am I?" There's disorientation. So they speak, they have full sentences, they're able to have some sort of conversation, but they are unable to comprehend what's happening. And then 5 being the best, they're oriented. Where are you? What happened? Why is the EMS people here? Somebody can have a seizure and not know what happened during the seizure, but they are conscious, alert, and oriented if they are told, "Hey, you had a seizure." And then when you talk to them in a second and they say, "Yeah, my name's Joe. I think you guys are here because I had a seizure." So they are confused on what happened during the seizure, but they're no longer confused because people that have seizures are not going to have that kind of memory. But now that he's able to retain information, he has that memory now, and he's no longer confused. He just had to have that explained to him. So that person would be oriented. Verbal responses in children is going to be a little different. Pediatric GCS, you may have to go off of their crying, their smiling, their inconsolability, agitation, those kind of things. If it's inconsistent with their age, consider it altered. Motor response. Decerebrate posturing responds with adduction, internal rotation of the shoulder and pronation of the forearm. So decerebrate posturing, think of it as kind of pushing out of the body. It's an extension to pain. This is actually more severe than the no motor response whatsoever. Flexion in response to pain. Think of it as everything pulling into the core, or decorticate response. This is better than the extension, but both of these, flexion and extension, are worse than the no motor response. Somebody completely unresponsive due to an overdose of drugs may have a motor of 1, but a person that has a traumatic brain injury and may be getting ready to go into seizure and die may have posturing, or the extension and flexion. These diagrams here show an abnormal flexion and an abnormal extension. So decorticate posturing, as you see there with the flexion, everything's going to the core. Everything's pointing in towards the core, kind of holding on for the last amount of life left. With decerebrate posturing, everything's being pushed away. This is progressive. So as their brain starts to herniate, they will start with decorticate posturing and eventually turn into decerebrate posturing. That is when the brainstem is actually being damaged and permanent damage or death is imminent. Here is another example of how to remember the difference between decorticate or flexing and decerebrate or extending. If they are not posturing, it's only going to get better from there. 4 is when they withdraw from pain. Somebody starts an IV and they kind of shift their body away from it. You put a bag valve mask, put a BVM on their face, and they try to turn their face away from it. That is going to be withdrawing from pain or withdrawing from sort of stimulus. Localizing pain is if you start an IV on them, they reach over and try to smack the hand that's starting the IV. They try to smack that away. They purposefully move towards that stimulus. You put a BVM on their face and they smack the BVM off of their face. You give them a sternal rub and they try to grab your hand to stop you from rubbing their sternum. That's going to be better than if they just kind of lean away from the pain. 6 is at best. This is when you can ask them to wiggle their toes, make a fist, smile, stick their tongue out. They're going to obey these commands. Somebody being defiant and refusing to do these commands does not make a level 1. Having them make those kind of commands where they close their eyes or keep their eyes open, even if you tell them to close their eyes and then they forcefully open them up to be defiant, they are obeying some sort of command. Interpretation. Anything below 8 of a GCS score is going to be severe. Moderate is going to be your 9 to 12, which is going to encompass some of your more severe concussions, and then your minor is going to be your 13 and 14. When I was talking about earlier how a 3 is better than a 4 or 5, this talks about, this scale here shows the number of deaths when somebody is posturing. So a GCS of 4 has a higher level of death than the GCS of 3. The GCS of 5, which could possibly be your decorticate posturing, has the same amount of deaths as a person that has a GCS of 3. Let's go back to our young male with his head injury. His eyes were initially closed, but they opened to the sound of his name. So remember back to your AVPU. What score does he get for his eye opening? When he asked where he was, the patient said, "My shoes to change." Is this appropriate? Is this just strictly confused? Is this moaning and groaning, or is it inappropriate words that don't make sense? When asked to move his fingers and toes, the patient was able to comply and was able to move all of his fingers and toes. What score does he get for his motor response? Do the math, figure out his score, and tell me the head injury severity, or say it to yourself out loud. Since his eyes open to the sound of his name, he gets an eye-opening score of a 3. Since he said inappropriate words, but they were words that were formed, he gets a verbal response of 3. He did move all of his fingers when he was prompted, so he gets a motor response of 6. If you get something other than a GCS of 3 or a GCS of 15, you must write it out as a GCS score with the values of an E number, V number, M number, so we can determine which areas have been altered. With a score of 12, his head injury severity is labeled as moderate. Anything from a 9 to a 12 is moderate.